2026 for, again, a wonderful meeting. It's hard to compete against PCSK9 inhibitors, but I'm going to try. So there's no financial disclosures here. So bifurcation PCI, I think Dr. Serrano did a wonderful job talking about which patients should get 1 stent provisional or 2 stent. But I think when you do it incorrectly and don't use the appropriate technique or the stent, there is significant complications and side effects. We have not only abrupt closure, we heard about stent thrombosis, restenosis, both at the side branch, which is the Achilles heel, or the main branch, but also we've seen cases of stent malformation, geographic miss, stent malapposition, all of which is what we fight against the surgeons when we're talking about complete and perfect revascularization. So here's the case, simple case, the bifurcation, LAD diagonal. Are you going to wire the side branch? What technique are you going to use? This is a great provisional case. But what I often see, especially in the United States, is quick wire, quick direct stent, and then what happens? The diagonal shuts down. So this is, luckily, this operator wired the diagonal so that you could actually go back in after a pot and rewire it and dilate with kissing balloons and save the diagonal. So we're not in the business of closing vessels. We're in the business of revascularization. And if we're going to do a case which is simple, keep it simple, but make sure that you keep it open. Here's case number 2. This is a woman who has mantle radiation from Hodgkin's lymphoma, has coronary disease, had a stent in the prox LAD, subsequently came back with angina. Of course, where did she restenose? At the ostium of the LAD, and there's progression of left main disease. Now, could she get a mammary? She saw a surgeon with mantle radiation. Her chest is scarred, so she opted for percutaneous revascularization. Here's an AP cranial, and you see that the left main is tight and hazy. There is a patent stent at the prox LAD, but in an ostial restenosis. So here, this is a provisional case. We IVUS both, we predilate both, we finish off, and this is the result. Anybody have an issue with this result? Your eyes go to the ostium. Yves said, I'm fine. Yves doesn't have to image anything. He's got IVUS eyes.
Can you have another view?
Okay, so another view I don't have for you because I only have 10 minutes,
Yeah.
but it looked good. So
looked good,
here
yeah.
the key was pot was not done. Okay, imaging was done. It was expanded. Pot was not done. And they did not image the origin of the circumflex.
Oh.
Now, we've got some predictors for bailout circumflex stenting, and you're going to hear about that from Jacek next. But clearly, if you have an MLA that's small or a calcified nodule or distal left main that's layered with plaque, you're going to have potentially a bailout situation or restenosis. This patient came back with angina clinically a year later, where at the ostium of the circumflex. And then this was completed with a 2-stent technique, and we finished up, and she's done well since. Here's a patient, smoker, stroke, peripheral vascular disease, abdominal aortic aneurysm, angina, syntax score over 35. The surgeon saw him, and the surgeon ran out of the room, said, I can't operate. So this is our patient now. How are you going to treat this? Well, this is, it's a retroflex circ. The ostium is okay. LAD diagonal, also the origin of the diagonal is okay. So these are 2 sequential provisional techniques. Here it is. We finished. We used resolutes here. We potted. We imaged. Everything looked okay. He hemodynamically tolerated it. And oh, by the way, he has a creatinine of 2.5 and a GFR of 20. We used very limited dye because we used imaging. And the thing to remember about this, and I've learned this from Yves and many other operators in the European Bifurcation Club, is ostial left main stenting. First of all, get the right view, which often is the LAO cranial, and make sure you hit both the inferior and superior border of the ostium if it is diseased. You'll know that only by imaging. Again, left main PCI, and I agree with Dr. Serrano, most all bifurcation PCI, and in my lab, 95% of all PCI is image guided, but left main PCI, there's a mortality advantage to imaging. You should image. The other thing that has happened, it's happened to all of us, is longitudinal compression. After you go in and do the pot with a large balloon, 4-5, sometimes a 5-0 balloon, and if you are not careful, and oftentimes if you're not watching the fellow who's doing it, they inflate with the pot, they pull back the balloon, and the guide jams in, and what you have is longitudinal compression of the ostium of the left main. So now what you did, you have to redo because the ostium is uncovered. So this is something you have to be careful of. This is case 4, a case of mine from New York City, a 111 left main. This gentleman did not want surgery. He had class 3 angina, EF of 50%. These are large caliber vessels. Since I imaged them, I can tell you the LAD is 4.0, the circ is 4.5, and the left main is nearly 5.5 millimeters. You see IVUS images of all 3, the left being the circ, the middle being the LAD, and then the right being the left main. Here I used a collat stenting technique. Remember, technique matters, and we didn't have a chance to go into the detail of technique, but it requires 2-pot recrossing. This is how we finished. There's a 4.5 onyx in the circ, a 4.0 onyx in the LAD, and a 5.5 pot. And this is my MLAs at the end. I've got 10, 11, and 12, or actually greater 18 in the left main, and I'm okay. Now, the reason I say that is what we just talked about. A 2-step kiss is necessary. It's mandatory in any 2-stent technique. What is a 2-step kiss? 1-to-1, non-compliant balloons, the size of each branch. You go up high pressure in the side branch, come down, go up high pressure in the main branch, come down, and inflate and deflate sequentially together in both so that you repurpose the carina. This is mandatory. A lot of people miss it. Don't do it correctly. Do it not sequentially and appropriately, and you're going to have a jungle, and your risk of stent thrombosis goes up. This was mentioned. You really need to know your stents. You cannot stretch a 3.0 stent and make it a 5.5. And here's why. You need appropriate stent sizing for scaffolding. Every stent is different. You have to have some radial strength in a lot of your cases so you don't have longitudinal foreshortening. You need to make sure that side branch access is achievable. In my last case, I needed a 4.5 side branch access. That's why I used Resolute in that case. You need to be able to see your stent so that you're post-dilating appropriately. Not everybody has stent boost, and so this becomes very, very important. So this is my last case here. This is a 85-year-old woman post-CABG. Circ graft is closed. She's got class 4 angina. Nothing would go here. It ended up being a roto case with an Amplatz guide. Subsequently here, I dilated, wired the bifurcation, and then I ended up with a sequential stenting of the OM and the left main and got a very nice result. This was actually a live case. This is a 90-degree angle, and you need real radial strength here. And this is why you need to pick the right stent, and you also need to make sure that there's no foreshortening. All of these larger stents will foreshorten once you expand them. And Resolute Onyx has the least foreshortening. All of them have a little bit of foreshortening. We only have 4 FDA-approved stents in the United States, and this is something that's very, very important. And finally, this is an LAD diagonal. They tried to do a tap technique, and what happened? They actually missed the true ostium of the side branch. This is what Dr. Serrano was talking about, either a nano or mini DK crush technique. That's why it works. You cannot miss the ostium. This is what we call a geographic miss. I call it just bad technique. Okay, the patient doesn't know that you missed this. They come back with angina. They came to you with angina, and the diagonal is going to cause the same amount of angina as the LAD. So in conclusion, understanding the bifurcation morphology and disease distribution with imaging will allow upfront strategies to be decided and reduce these complications. The choice of the technique and understanding the current DES matrix and size limits and side branch access will allow you to have durable results. And the risks of complications, including restenosis and stent thrombosis, can be really averted using appropriate understanding of these concepts. Thank you very much.
Thank you.